Good morning, everyone. Assalamu alaikum, and thank you so much for coming up here to this presentation. Today, we are going to talk a little about the psychology and errors in healthcare because there are deeper issues when it comes to quality and patient safety. I guess I give some brief about myself at the introduction. But a lot of you never heard about my start with the safety issues, safety of the staff, safety of the facility. I started with oil field. I've been a medical doctor in an oil company, and the oil companies and those rigs. It's called a rig. Al-Haffar, the driller. It's called rig in the oil industry, and mostly I've been working in the same setting, sort of the driller and the camp and the staff, and it is a very dangerous industry, by the way. This is the first time in my life, in my whole life as a medical doctor, to hear about what is safety as a concept. It was absent. I'm talking about like more than 15 years back. Okay, I'm older guy now, but 15 years back, I've never heard about what is safety in healthcare. Now I've heard about it in the oil industry, and what it was my start, to get more interested in quality and patient safety and safety of the facility, safety of my staff, because the dangers of this industry. Okay, so these are my error boxes, okay, if we can call it. So imagine we have a big box, this big box, it's called errors, okay? This blue box, it's called errors, medical, non-medical, lapses, slips, okay, intentional, non-intentional, whatever error, we have big box called errors in our hospital or in our healthcare facility. Now, inside this box, there's a smaller box, okay? Smaller box called close call. Now we are, near to cause a patient harm, but it didn't happen, alhamdulillah, thank God. Okay, so for example, we were about to transfuse wrong blood to wrong patient. So we were about to do wrong procedure, wrong operation on the wrong patient. So this is close call. We are now approaching to harm the patient, or at least we've done like a trivial thing, but it didn't harm the patient. So this is close call or near miss. Inside this box of near miss or close call, there is a smaller box, okay? It's called adverse event. Now the harm reached the patient already. We've done harm to the patient. We transfused wrong blood. We did wrong operation. We misidentified the patient for a procedure or treatment. We've done wrong route or wrong route for a medication. We've done wrong dose. We didn't consider the allergy of the patient. Now we do harm to the patient. This is the box of adverse events. Within this adverse event box, we have a smaller box, okay, inside this adverse events. It's called hidden harm. The iceberg, okay? The hidden thing underneath the water surface actually is the major part. So within those adverse events, we captured or we've experienced or we got reports about there is big genre called hidden harm. And it occurs everywhere in the healthcare because people are scared to report, to communicate, to speak up, because this poor nurse, if she reports, actually, it can be terminated or get sanctions or, some disciplinary action. This physician can be harmed because of this report. So what happens in OR, for example, operation or operating theater, it stays in OR. So we are facing the hidden harm all the time. That's why the last question to Dr. Mu'tasim about how communication method, what's the best communication method we can use as patient safety advocates or quality professionals? Actually, not checklists, not anything else, not audit lists, not documentation, to open your door up, okay, for people to talk to you. This is the best, okay, in order to capture all of those things around. Now, in the hidden harm box, we have a smaller box, okay? It's like the gift boxes. We have smaller boxes, okay, all around in a big box. So there is a smaller box called risk thereof. Now it's becoming more serious. actually, because risk thereof, simply put, is the near miss or the close call, okay, of a sentinel event. Very harmful event, okay? So now it is still near misses, but it is very harmful. And it is within the hidden harms, okay? So we put the cannula into the patient's vein, white pour cannula, in order to transfuse blood. But at the last minute, we discovered that this blood is wrong, okay? It didn't match with the patient, okay? This is wrong blood, or there is a different name on the barcode, whatever, okay? It happens all the time. You couldn't imagine, because if you are in the healthcare system, it's very rushy, very complex, very, you know, bothering, a lot of workload, a lot of things we will talk about later. So this is risk thereof. Now it is not just a near miss, because actually, if it happens, it's going to lead to patient severe harm, or the patient can be killed easily because of this risk thereof. So it is a hidden harm within our systems. It happens, but people did not report it because they are scared. So, or okay, no harm happened, so it's fine. Okay, it stays here in this room. Okay, never report. Okay, risk thereof. And definitely within this box, we have the very small box, the tip of iceberg, the sentinel event. And believe it or not, a lot of sentinel events are not reported, are not, you know, reported even to the local leadership in the facility, especially when the hospital is large or medical city. So a lot of things are here, and this is the deep psychology of people, why people do not report, why people are scared in healthcare system, why people are hiding things. They are hiding things, okay? And us as patient safety and quality advocates actually are pointing our fingers to those people, okay? So the head nurse is the cause, the medical director is the cause, the head of department is the cause. And actually we will learn today about some psychological things about the patient safety that lead to all of those things we are facing every single day in our facilities. So these are my boxes I love, and hopefully it's been beneficial somehow. Now, if you look at my lovely organization, Institute for Healthcare Improvement, and I encourage every single one to make an account this very morning after this session, to, you know, indulge yourself into quality and patient safety resources for free on this using this website. So there is a publication called Zero Harm in Healthcare. It's done by the leadership and some researchers by IHI, Institute for Healthcare Improvement in Boston. Zero harm, not zero error. Okay, people, especially my dear colleagues from non-clinical backgrounds, there is no zero error in healthcare or any other industry. Zero error means we are not human anymore, or this machine will not have any problem, even with the regular PPM. But errors are everywhere because we are still in life, okay? We are not in paradise yet, hopefully, inshallah. But, you know, so errors are everywhere, but at least to minimize or mitigate the harm towards what's called high reliable organization. So we are not harming our patients, or we are mitigating this as possible or minimizing this as possible. So zero harm, not zero error is the right term here. And definitely, I love IHI because this guy, Dr. Donald Berwick, the Sir designated by the Queen of the UK. Dr. Don Berwick, I've met him a couple of times, and actually he's a guru in healthcare quality improvement all over the world. Actually, this guy is not extraordinary, not normal, okay? So please try to learn from this IHI to the extent I paid them a visit in Boston while I've been in Harvard University course for value-based healthcare. Now, talking about errors, and definitely sentinel event is the major chunk of this, and it is the miserable chunk actually, but a lot of lessons can be learned from sentinel events. And there is updated definition in 2021, thanks to my dear colleague, Dr. Hussein Riyad. He considered himself my student. No, we are partners. We are exchanging experience. He transformed his life by quality and patient safety, and I like this about him, and hopefully, inshallah, is doing great right now. So there is sort of updated definition 2021 because the older definition was developed in 1996. This is a hyperlink, but we don't have that luxurious time to go through. So certainly event policy, pay this link a visit and try to pick the right policy for your facility. So for example, there is one for hospitals, one for ambulatory care, labs, and so on and so forth. Okay, certainly event policies. Okay. But first, there is some psychology basics we have to look into when it comes to patient safety. People like shortcuts. Okay, doctors, nurses, technologists, technicians, non-doctor specialists, even admin staff. We are, as human beings, love shortcuts. Okay, shortcuts. The simplest way to do things. Okay, so we have policy, we have protocol, for example, but we like to do shortcuts. So please, my dear nurse, do the preparation of this, high risk, whatever thing, because as a clinical pharmacist, busy right now. So, and the doctor is on his way. So this is a shortcut, okay? We are very busy. We are, sometimes we don't like to do so. So shortcuts, workaround, drifts. So this is the human nature. And people tend to resist the change, the new things, the different things. So we used to do so this way. And now, Dr. Mu'tasim, you are telling me to use timeout checklist, for God's sake. What is that? It's different from what I've learned or what I've practiced before. So it's new to me or different to me. So sorry, I'm going to resist you, even if I'm not declaring this, but this is the human nature we have as patient safety advocates and quality professionals to embrace this fact, okay? This leads us to what's called Swiss cheese model, which is the top-notch thing. It is a psychological theory, actually, not only for healthcare, but for a lot of systems all around the world, developed by the psychologist from University of Manchester, James Reason. So we have layers to guard against the error to happen. And those layers, because we are all human, so we are, as policymakers in patient safety and quality, we are doing some holes or some gaps unintentionally in the law or policy or procedures. So the error can, take its root through the holes in those layers of Swiss cheese. At the end, if our layers are not, aligned all together and are not, couple of layers to prevent, so I came through, this error came through this first layer. So the second layer should stop the error, but the error came through the second layer, for example. Okay, blood transfusion, because believe it or not, it is very common error and it is very underreporting. The same for the medication errors at the bedside. Very underreported by the nursing staff, and now we know why, because people are scared, and we will discuss this in the coming slides, inshallah. Okay, so we've got blood. Okay, how to get blood for a patient? There is a request, okay, and this request has to have an indication why you need this blood for the patient. Okay, so there is some justification, and it was sent electronically or paper-based to the lab, and the lab received and verified, and maybe contacting the treating physician why you need blood for this patient particularly. Anyways, okay, justified and everything is okay. So now we are going to match the blood, the sample from the patient and our blood in our blood bank, or if we will have some donations to whatever. Okay, but at least we will do the matching with our blood bags, okay, in the blood bank, and then supposedly this cross matching was done with good reagents after quality control in the lab, and everything is okay, and the patient is identified very well, and then this blood will be delivered to the receiving nurse or porter, okay, to the ward the patient lies within, and then the receiving nurse will double verify, okay, the blood, okay, this is the same patient, same file number, same date of birth, for example, whatever, because, and then we will go to the bedside and doing the setup, the warmer for the blood, and the set for the IV infusion, intravenous, and so on and so forth. And then we need to double verify now the blood before just transfusing to the patient. Sometimes the head nurse or the other nurse to verify with me as a nurse is very busy or not available, or we have a lot of shortage of nursing staff, as universally known everywhere in the world. Okay, so now I'm in a trouble. I should transfuse or not? Okay, and then I started to transfuse the blood, whether it is verified or not, and the blood either wrong or either good. And even if it is very good to the patient and matched, actually still there is a potential from any blood, because it is like a foreign material transfused through the IV system to the patient. Actually, there is a potential for harm to this patient, like anaphylactic shock or some allergic reaction or whatever, okay? Hemolytic reaction, and so on and so forth. So every single step I've said, this is a layer in the Swiss cheese model. Any hole in every step can lead to the other hole, to the other hole, till the patient. So if the patient was misidentified in the lab or in the request, actually we came through all the holes, and now we are transfusing wrong blood for the wrong patient, and so on and so forth. So this is the idea behind the Swiss cheese model. And here it comes, the walls, the layers we are putting through policies, procedures, protocols, but we should convince people to use those, to rationalize this to people using those protocols or policies and procedures. Otherwise, the psychology basics will kick in, shortcuts, drifts, and it's different to me, or I'm not familiar with the new policy. And this is Swiss cheese model for Corona, COVID-19, or COVID-20 even infection. If there is no good layers like protective measures and washing hands and don't touch the masking and vaccination, then the infection can keep spreading all the way. Now, how to deal with those kind of errors, doctor? You have a lot of boxes. Yes, error boxes. We have a lot of boxes. So basic just culture, 3 things, and I guess my dear colleagues yesterday went through it very fast: human error, at-risk behavior, and reckless behavior, and developed by Dr. Frankel and Leonard. This is the old model, and now there is starting 2010, Dr. Frankel actually modified the just culture into 5 threats, not only 3 threats. So we have to update our knowledge about this. And then there is a nice algorithm to deal with those things. So you can go through it. And you can download this
Rahman,
from...
let me interrupt you, please.
Oh, yeah, please.
I think you are going to hurry because of time. You have a lot of time. Don't go hurry. We need to get more from your knowledge. So don't take us slow. We need more explanation. We need more things. You have all the time. You still have more than 25 minutes.
25 minutes?
Yeah. So
really?
Please, yeah. Take your time, because really we want to enjoy your and take
thank
more
you so much, Dr. Khalid. It's very generous of you. Okay, thank you. Dr. Khalid, my friend, to the extent I paid him 2 visits to Muscat before. So his ex-advisor at the Minister of Health in Oman. Okay, so those resources are actually available online. You can just search for it, search for the resource, and then you can download it very easily, okay? But I guess I will not be able, like my dear colleague, Dr. Mutasib, will not, just because it is very limited budget time, so we will not be able to go through every single thing, but at least to share with you the resources available, and you can just go through Google, okay? The knowledge guru in the world now, and just download the resources. And all of those are free resources. That's why I'm sharing with you very fast, because you can just download it. Okay, so this is algorithm, how to deal with the errors. Okay, and I guess Dr. Khalid, Dr. Ahmed Safat and Dr. Hussam Madani, mashallah, elaborated very much on the medical errors yesterday, to the extent I reformed all of my presentation, because they, mashallah, did a very amazing presentation yesterday. And actually, people who did not attend, they missed a lot. Actually, I'm telling you guys, you missed a lot yesterday. So here, a Canadian source from Canadian Patient Safety Institute. You can download it as a PDF from the Canadian Patient Safety Institute. And I'll tell you about my YouTube regarding the free resources for patient safety at the end of this presentation. Shall I promise, inshallah, about the Canadian Patient Safety Institute. So you can just download it. You can use it in assessing the patient safety culture in your facility. Plus, you can use those things within your safety huddles, for example, the safety rounds, the leadership, patient safety rounds, and so on and so forth. But it's a lot of things to be checked out. So just download it and, take your time with your team in the hospital, in your healthcare facility, just to learn from those resources for free, and try to get this sense of international experience in a local context, like here in Saudi Arabia. Okay. Now, in 2015, after the high reliability organization movement, DNV, actually DNV, it's a company based in Norway, but they are doing accreditation now. It is in oil industry, basically. Okay. In the field of oil. And I told you, first touch of my life with the safety was in the oil industry. Like we are learning a lot now in the patient safety from aviation industry, from airplanes and aircraft. The same, I've been trained in the oil industry. That's why I'm very keen about the safety culture in general, not only patient safety, and you will see in the coming couple slides, inshallah. So DNV actually is Norway-based company. It's in oil industry, but for like a decade or more now, I guess, they are working in healthcare field, and even they have developed healthcare standards. And it works now in side by side with Joint Commission in the United States, and they have a lot of programs. So they published in 2015 a paper, a position paper called Improving Assessment of Healthcare Safety Culture. And they went through all of these 5 things. And you can just look at them, and you can assess yourself by this statement in this picture. For example, pathological environment for safety. Pathological, it's a disease, okay? So who cares as long as we are not caught? If you have such culture or mindset in the leadership or your staff, so you are in the, at the lowest ladder possible here, okay? It is pathological. And then reactive. Safety is important. We do a lot every time we have an accident. So we are just reactive to problems, to adverse events, to central events. Now we are in the reactive phase. And I guess a lot of healthcare facilities in the whole world, cumulatively, they are either pathological or reactive, believe it or not, okay? We are not talking theory now. We are just deploying the theories into our life practice. Calculative, we have system in a place to manage all hazards. We have system in a place, okay? And it's very well known in the oil field, in the nuclear plants fields, and aviation fields. They have system in place to manage all hazards as possible. That's why those kind of systems are safer than healthcare system. And then we have a proactive. We work on the problems that we still find. Proactive. They are proactively trying to capture errors by near misses, capturing by, safety rounds, open communication with the staff and the leaders and the patient and families. open communication, conversation, a human-to-human interaction, a human-to-human interface, okay? So, and finally here, we have generative system. Safety is how we do business around here. This is our culture. We are talking safety at the beginning. From the start, we are talking safety. Is it a patient safety concern or not? We will cut the budget. It's going to affect our patient safety or not. We are going to let some physicians go for whatever reason, some nurses to go. We will then let go for whatever reason. Is it affecting our patient safety in our facility or not? This is the generative culture. I guess some little healthcare facilities are dealing with this generative idea. Whatever, you know, level of practice in the in life, but you know, there are some healthcare facilities doing so. They are talking safety, the major concern, and the leadership, you know, meetings and the medical board meetings and the nursing meetings, they are talking patient safety. Okay. Yesterday, I've heard a lot about the reporting. People are talking about reporting all the time in the patient safety because it is, you know, sort of risk assessment and risk analysis. But, you know, reporting, as you can see here from CPHQ, when they've been analyzing something related to healthcare associated infections, CPHQ, it is a governmental agency in the United States called Agency for Healthcare Research and Quality. Reporting is the least thing we can build upon. Reporting. This is the first stage, if we can call it like this, okay? Reporting. So reporting alone is, you know, sort of basic things, but a lot of the challenges in this area because we are not considering the blocks over the reporting. So for example, just culture. Are we dealing with the reporting with just culture, or we can punish people because they reported already? This nurse has been punished because she reported something happened during the surgical operation. So this is just culture. So the reporting will be affected, will be harmfully affected because just culture is not there. And then flexible teamwork. Are we working in teams or in silos? So this is OR, you have nothing to do with us. Okay, we are physiotherapy department. Sorry, you don't have as orthopedician or neurosurgeon, you don't have anything to do with us. Okay, sorry, sir, we are nursing department and you are medical board. Are we talking this? If we are talking like this, so actually this just culture, this reporting will be degraded because actually it's a building blocks. It should be integrated all together. Any one in the blocks upwards, actually it's gonna hurt the one below. So for example, if we don't have good just culture, we just talk just culture, it's just talking. Actually, the reporting culture will be fade away, okay? Will fade away. And just culture without teamwork, it doesn't work. And then if we don't learn from reporting and just culture, we don't learn from near misses, from sentinel events, from adverse events, from whatever events, actually, okay, all of those will break down. The teamwork, the just culture, the reporting. And then the final brick, HRO, high reliability organizations. Is our system safe enough or not? So any block can, you know, lead to any problem with any block can lead to a lot of problems in the down their blocks. So reporting only is not the case. Reporting only is not the patient safety system we look for. Actually, it is an integrated system. What about the feedback to the team reported to us? If the team, you know, felt like, okay, I'm reporting. Yes, there is just culture. They are not punishing me because I'm reporting, but you know, there is no feedback. There is no learning from this. So thank you so much. I'm not gonna report once again because, you know, in vain. It's, you know, haphazard thing. It is, there is no value from this kind of reporting. Okay. So one dear colleague just asking me over LinkedIn a couple of days ago about what is the best indicator to monitor the reporting. Okay. I told her, actually, there are a lot of theories in this, but my best option to see the intensity and the number of reports. Okay. So the number of reports are increasing, or, it's fine. Okay. But the most important thing, the intensity of the reports. For example, we are encouraging people to report. Okay. We've done awards for reporting. Okay. If you report more, okay, we will give you an award. Okay. It's great. So people started to report. To report what? To report near misses, to report just circumstances can lead to errors. They are not reporting real harm. They are not reporting adverse events. So we have problem reporting because people are not empowered enough to report the real harm to the patients or real problems in our system. Even medical harm or non-medical things like, potential for fire or whatever. Okay. So, it's a culture, it's a mindset. It is not only a policy and a procedure and a protocol. Please, patient safety people, quality people, it is a human touch. It is a human interaction. We are all human. We need this touch. Okay. Not only documents. Where is the checklist? Okay. Checklist. Okay. It's all great. And you are doing this in front of me and they are timeout. So it's great. No, they are doing this checklist in front of me because I'm there. I'm the quality or quality director in there. So they are doing it in front of me. But what about my behind my back? Okay. If they are not going to do this, so actually it is not a culture. It is just, courtesy. Okay. Dr. Ahmed is here. So we are going to do timeout. Dr. Ahmed, the quality. So no, it should be a culture. So how to do so? To communicate openly with people, to listen to their concerns. You will have this chief surgeon telling you, Dr. Mu'tasim, actually, I'm not convinced at all with this timeout ball, whatever thing. Okay. Sorry. Yeah, you will hear this. So what will be our reaction? It is required by CPHQ standards. It is required by JCI standards. It is required by the leadership. There is a memo from the medical director or hospital director. Those all things will not work because he is, as a human being, is not convinced yet. You should rationalize this. Give him a rationale behind why you are using, sir. Sir, listen, please. Okay, last month, for example, because of lack of using this checklist, actually, we've got a sentinel event. We did wrong operation from whatever, our dear colleague, okay, yeah, it happened and there was a disaster in our hospital. We've done wrong procedure to a wrong patient. Do you like, sir, to do so for your patients? No. But my record is clean and I'm a professor in whatever university in the world and I am a big time consultant. Okay, sir, but we are trying to help. Can you tell me about the obstacles, why you are not going to use the checklist? Now we are communicating. We are communicating. Not everything OVR, not everything report, incident report, not everything checklist, not everything document in the medical record, but there is behind this, actually, there is a human interaction. If we, forget about this psychological touch, actually, we will not be having appropriate patient safety or quality culture in place. To wrap up, I have 4 theories to update from my humble experience for like 14, 15 years in quality and patient safety field. So I'm going to challenge you and please be patient with me. Okay, some people will object on my, updating those kind of theories. But guys, please listen with open mind, and we can discuss later in the discussion. Okay, okay. We'll go through fast. Theory number 1, 85-15 rule by Dr. Edward Deming. Dr. Edward Deming was a top-notch statistician in the world and a quality improver, but he was working with industry, not healthcare. Healthcare is different. Healthcare is very different, is very complex, and we will get into this theory later. So theory number 1, 85-15 rule It is not true when it comes to healthcare. What about 96.4? So 85.15, it means 85 problems in any given system can be attributed to the system itself, the processes of the system, the protocols, the policies, the practice, and 15% can be attributed to individual problems, okay? But in healthcare, guys, please believe me, from my practice, 96% is related or can be attributed to the system itself, to the leadership itself, to the processes itself, to quality people themselves, to patient safety staff themselves. Sorry, guys. Okay, I like all of you, but you know, it's real. And only 4 can be attributed to healthcare. Dr. Ahmed, what's your reference? It's been a good study done on the medical claims submitted to the court in the United States. Thousands of claims. And then they found that only 4% of those all the claims got the conviction, or you know, the doctor is convicted or the nurse is convicted. But 96% was dismissed. And this ratio can be manipulative to even more towards the system. 97% and the 3 only can be attributed to persons, because actually our system is the one can lead to problems with healthcare. One example, Dr. Ahmed Safwat told yesterday, informed about this. If you have this very tired nurse, worked for 16 or 24 or 84, 48 hours in a row, without good rest, without good food, and she might be sick or whatever, because we have shortage of nursing, we have a rush of COVID-19 patients, whatever the reason. Now we are setting the system to make errors, not because the nurse did the error, because the system around her or around him actually is, you know, yes, is pushing them towards doing or committing or omitting errors. So theory number 1, 85-15 in healthcare doesn't work. This is my first update to this theory. Theory number 2, second victim. It's a very deep and dangerous theory. Actually, second victim, when the physician or nurse or technician or whatever healthcare worker did a mistake, commit or omit, and the patient got harmed for whatever reason. The little baby got killed in our hospital. This mother in labor got killed in our hospital. You know, even if the physician or the nurse or whatever healthcare worker is trying to be arrogant enough or defensive enough, actually they are, at the end of the day, they are all a human. Something broke inside them. And that's why we have this incidence of depression among physicians and nurses and healthcare workers. I've been in the United States in January 2020, just before the COVID outbreak. And I listened to a lot of doctors, surgeons, and leaders. A lot of burnout are there in the United States, and it's a very well-known system in the United States as a workforce in general, and in healthcare in particular. People are depressed. They have money, they have life, apparently, but they don't have life actually. They are depressed. I have 2 colleagues, one nice lady and one nice guy, actually going back and forth to Harvard University for a week. And they are complaining all the time. They are fellow surgeons in an oncology program in the top-notch MD Anderson, Texas. And they are depressed. They are not happy with their life because a lot of things are in there. A lot of pressure are in there. So we have second victims all the time, even if they apparently they are doing arrogance or defensive. They seem like this, but they actually have a lot of problems. Sometimes this staff will quit the place, quit the hospital because of a lot of pressure, may quit the clinical practice. And I've met a lot of my colleagues and healthcare leaders here in Saudi Arabia, in Egypt, in the United States, and whatever in the world. Actually, they quitted the clinical practice because they were second victim. And one of the top-notch speakers from the United States I've met in Dubai, I guess, was an anesthesiologist who quitted because he was a second victim. And finally, suicide. And there are a lot of stories now about suicide among nurses in particular when they are second victims. Look at this painful survey done annually in the United States, National Physician Burnout Suicide Report 2020, and I guess 2021 is coming out. Look at the stats. What contributes most to burnout? This is just only one question of the survey. 55% of the physicians say too many bureaucratic tasks, shorting, paperwork. We couldn't deny this. And we have in quality and patient safety a lot of documentation, especially CPHQ accreditation. We couldn't deny this. Spending too many hours at work. There are workload, there are shortages, so we are covering a lot. Lack of respect from administrators, employers, colleagues, or staff. Look at the odds, look at the numbers. Actually, it is, and even the title of the survey, Burnout and Suicide Report. And I'm going to be, done with this kind of chart only because there are a lot more painful charts in this survey. Theory number 3, complex adaptive system. Healthcare system is a complex adaptive system. Yes, it's a complex and adaptive. Anything can affect healthcare. The economy, the politics, the healthcare workforce, the rumors, the culture, the religions, the creeds, everything can affect the healthcare system. That's why it's complex and adaptive. But adaptive to what? I went to Vancouver, the far, far west of Canada in 2016, in the winter, November, to be in this event, HSR 2016, about health systems research. And the theme of this event was the resilience of healthcare system. And even the health policymakers were laughing. Is healthcare system resilient enough? Look at the COVID-19. Saudi Arabia done a great job, mashallah. But what about United States, the UK, Europe? Big notched systems actually collapsed in front of our eyes because healthcare system is not that adaptive, actually. It is not that flexible. It is not that resilient. Actually, it is rigid somehow in things like credentialing and privileging, competency, and so on and so forth. So there are a lot of, things can make the healthcare system rigid. That's why complex adaptive system now, I'm putting a million underline under this adaptive. It is not that adaptive as we can imagine. Even I went in January 2020 to meet this guy, Michael Porter, the top-notch professor in Harvard Business School, to attend this value-based healthcare delivery, to listen to different things. Actually, the healthcare is reformulated now in a lot of countries, even before COVID, but what after COVID? We should reform even our mindsets as policymakers. Theory number 4, the last one, patient experience. Okay. I love the term, but not that much. Patient experience. Actually, Accreditation Canada is smarter. They've done people-centered experience or people-centered care. People, not patient. Because actually, what about our staff experience? If our staff are not happy, so the patient experience will go down. Simple like this. So patient experience, we have a patient experience department in our hospital. We have patient experience in the Ministry of Health. But what about the staff experience? What about the workforce experience? So I'm revisiting this kind of theory. Sorry, there is the fifth one because I added it just before the presentation. Accreditation is not a guarantee for patient safety and quality. And we can't tell why till the next morning. It depends. If you are kind of leader to get the certificate to be hanged on the wall, so, okay, there is no patient safety, there is no quality, there is no system, actually. Okay, if we get the accreditation because of the just medical insurance, so it is not system, actually. Okay, it's something else. And sometimes it is because of the accrediting body itself or the regulator itself. And final word, Dr. Khaled, because I know, okay. Final call for policy making and patient safety, because I've seen here in the, mashallah, the participants, there are hospital directors, policymakers in Saudi Arabia and other countries. So final call for policy making and patient safety for the current and future leaders. Informed decisions. Take your decision upon data and the mixed research methodology, not only data, not only numbers, but storytelling, qualitative methodologies in order to get the big picture. And finally, skip the ivory tower, please. Al-Burj al-Aji. Be a field guy. Go to the hospitals and visit them. Finally, guys, Ahmed Yahya Bahloul on LinkedIn, Twitter, Facebook, YouTube. You can visit my YouTube channel for this more elaboration about called Future in Saudi Arabia, how to learn patient safety for free. And this is my bio, simply put in Arabic. And thank you so much and be safe.
Thank you very, very much, Dr. Ahmed, about the amazing, very, very informative session. So I will take now the answers. I couldn't find the word really to express the wonderful presentation, Dr. Ahmed.
Thank you so much.
All participants are interacting. They are very, very happy. They are very interested.
Thank you so much.
So would you please stop sharing screen so we can go to answer the question?
Okay, yeah, thank you.
Can I say something? Taking around. You can take the round with us.
انا بس عايز اقول حاجه بالعربي. انت متخيل ان انا عندي محاضره دلوقتي الساعه 11:30 بعد 4 دقائق وواقف بره المحاضره فاتح محاضره استاذي الدكتور بهلول. بجد ربنا يبارك في حضرتك او البروفيسور دكتور بهلول وبصديقي الغالي دكتور معتصم. انا استمتعت جدا بمحاضراتكم اليوم. انا بس عايز اشكركم قبل ما ادخل الستيج. كتر الف خيركم وربنا يزيدكم من علم يا رب. شكرا دكتور خالد على انك سمحت لنا بالفرصه الجميله دي ان احنا نتعلم من كل اساتذتنا.
دكتور حسام مدني with one of the corner of this event. He helped in each step.
ربنا يبارك فيك. كتر الف خيركم. حبيت اشكر حضرتك دكتور احمد دكتور خالد دكتور معتصم. جزاكم الله كل خير. شكرا. السلام عليكم. مع السلامه. مع السلامه.
Let's now take the questions for Dr. Ahmed. They are, but this question is from Dr. Mu'tasim, but it's okay. Greeting to everyone. Who is deciding who the RCA root cause analysis team members are? So who select the root cause analysis team members?
Okay, back to RCA. I guess this is for my dear colleague, Dr. Mu'tasim. Actually, the one who suggests is the quality facilitator or patient safety officer to suggest to the leadership or to different leaders in your hospital. But there is a common mistake when it comes to root cause analysis team. We've seen a lot in our hospitals. Actually, we are inviting the service leaders, rather the people involved in the frontiers or the frontliners that they are delivering the healthcare services actually. And this is a big mistake because when it comes to leaders, sometimes they are not into the process like the people doing the procedures themselves. So I do not object to have leaders in a meeting, but another meeting with the frontiers, the people involved in the process and even in the incident. Okay, that's it.
Okay. The second question, they are asking risk thereof treated in same way as a sentinel event.
What's that? Sorry.
The question is the risk thereof?
Thereof. Okay. I've got
treated
so,
in the same way as a sentinel event?
It has to be. Why? Because next time, if this risk thereof, the near miss of a sentinel event, just let go, it's going to be a sentinel event for sure. Definitely. So it is a major opportunity actually to learn from the risk thereof because it turned out into a sentinel event in the near future. Okay.
One more time. I think there is no more question. There is question, but I think it's outside the presentation. If you can help them from Marwa Al-Kholi, can you recommend, this is, can you recommend a resource, link or technique for detecting the nursing staffing plan for ambulatory care? Do you have any resource for her to detect the nursing staffing plan for ambulatory care?
Okay, just Google it, nursing and staffing plan for ambulatory settings, and you will find a lot of sources and yeah, on Google.
Okay, I think there is no more question, but I like the presentation. I like that people really like the shortcuts because of some of the things are related to the shortcuts. You can spend more than 1 minute, but you can prevent a huge mistake or a sentiment even in that 1 minute.
Yeah.
1 minute checklist, 1 minute, just 1 minute.
Yes.
I also now really I am watching for the second time the movies series The Good Doctor. I don't know.
Yeah, the doctor, I guess, the doctor.
The Good Doctor. The Good Doctor. It's called The Good Doctor. It's now in Netflix. So
Okay.
yeah, it's really an excellent thing. All what we are talking about are there before. How to report. Well, yesterday I saw that series about, they told the head, no, I should have report. I save patient. I save for the hospital like this. He had the culture. He will report about himself like this. They told him, you will lose your job. Yeah, but I will save patient. I will save other stuff like this.
Wow,
So I advise everyone, every single advice from here, all the patients, this is a very excellent series. The Good Doctor, just search about it. You can find, I think, maybe in YouTube or Netflix. So there is no more questions. Dr. Ahmed will ask. I don't want to finish the session, really, because Dr. Ahmed will ask. Ahmed usually is the source of update in quality and patient safety. If I need something updated, I always call him.
Thank you so much, Dr. Khaled. It's been very nice of you, and thank you for the kind invitation. Thank you for all of our colleagues. Now, mashallah, we have a record of participants this morning. Thank you, and hopefully it's been sort of beneficial for my dear colleagues, because I like to be a field guide to feel my colleagues. I'm not like an inspector as a quality director, or we can communicate openly for about whatever we can talk about. Okay, we are all a human being and we are learning. It's a learning curve. Okay, theories are not Quran, is not a holy book. Okay, it's just talk. Okay, we can build upon our experience to evolve actually the current theories, as I updated you with 5 concepts or theories in order to challenge your open-mindedness, inshallah, and hopefully it's going to be reflected on the patient safety in the near future in the region and the world.
Thank you, Dr. Ahmed. Thank you again and again, and we hope that you will accept our invitation regularly to be with us.
My pleasure, Dr. Khaled. My pleasure. Thank you so much.
Thank you all, and have a nice day. Meet you tomorrow in the same time. The time, because most of the people asking about the time, it is 9 a.m. Cairo time, 10 a.m. Saudi Arabia time, 11 a.m. Muscat time. Thank you very much. And all the session, each day, only 1.5 hours. Thank you very much, and see you tomorrow.
Thank you.
Dr.
Take care.
Bye. Bye.